Hello, everyone. My name is Jia. I'm a fifth-year PhD student from Dr. Diane Burgess Lab. The topic of my today's talk is intraperitoneal catheter failures, a comprehensive analysis in patients with type 1 diabetes and in a rodent model. Diabetes is a worldwide health problem affecting more than 400 million people globally, of which type 1 diabetes accounts for 5 to 10%. Type 1 diabetic patients suffer from severe deficiency in insulin production and thus require lifelong dependence of exogenous insulin for survival. Over past decades, insulin pump therapies become more and more popular. Currently, there are two types of insulin pumps available on the market. One is an external insulin pump with a catheter placed in the subcutaneous layer, so it is called continuous subcutaneous insulin infusion. The other type, on the right hand, is a fully implantable insulin pump with a catheter inserted into the IP cavity. So it is called continuous intraperitoneal insulin infusion. This is also a focus of our talk today. With continuous intraperitoneal insulin infusion, insulin is directly delivered into the peritoneal cavity and absorbed predominantly into portal system. And thus, continuous intraperitoneal insulin infusion more closely mimics the normal physiological mode of insulin delivery compared to subcutaneous insulin therapies, which allows for more stable glucose control and a lower incidence of hypoglycemia. In addition, current diabetes care has an emphasis on a fully implantable closed-loop insulin delivery known as an artificial pancreas. As this figure shown here, when linked with a glucose sensor, continuous intraperitoneal insulin infusion has the potential to serve as a part of an artificial pancreas. For this system, initially a surgery is needed to place the implantable insulin pump as well as the associated insulin catheters into the body. The pump has a battery which has a life around 5 to 7 years. Therefore, a long wear system that can continuously function ideally for up to 5 to 7 years would be more patient-friendly and would result in more patients electing this treatment option. Unfortunately, in the clinical practice, continuous intraperitoneal insulin infusion system wear is shortened by catheter failures, typically known as catheter obstruction. The catheter is the part of interest for this work. Basically, catheters are composed of three parts: a polyethylene inner tubing, which is allowed for the insulin passage through the lumen area. Outside is a silicone tubing to protect the inner PE tubing and provide the mechanical support. In the distal end of this catheter, as the figure shown here, there is a silicone tip which allows the delivery of insulin into IP cavity. According to clinical observation, there are four types of obstructions. First, tip blockage. So as this video showing here, an occlusion deposit blocked the tip end. As this occlusion tissue is still soft, so insulin still able to pass by the blocked tissue and delivered into the IP cavity. The second case is tip encapsulation. So in this case, the occlusion tissue at the tip end grows bigger and covered the distal tip like a sock. Thus, this type of obstruction is also known as sock type. So the third one is the worst scenario when the entire IP portion of the catheter is fully encapsulated. And as you can see here, the surgeon is trying to remove this encapsulation tissue by surgery. The first type, which is not shown here, that is called lumen occlusion. So lumen occlusion occurred when insulin precipitate in the polyethylene lumen area. Since the year 2000, a new formulation, insulin U400 insulin was launched to the market. The improved stability of this drug led to a reduction in the occurrence of lumen occlusion. However, there still remains an unacceptable incidence of catheter obstructions. Each year, over 10% of patients experience catheter obstructions. In particular, tip obstructions accounts for the most cases, which includes tip blockage and tip encapsulation. However, the root cause of the issue still remains unknown. So as this is a combination product, both drug and device may have a negative effect on the catheter-associated insulin delivery issue. It is widely accepted that protein aggregation-associated immunogenicity has the potential to provoke protein-specific immune response. So here, Sanofi U400 insulin is the only available implantable insulin on the market for this system. So this is a zinc stabilized hexameric insulin. However, this hexamer may undergo the deterioration in some specific conditions, for example, agitation or hydrophobic exposure. And this deteriorated hexamer to monomer may continuing unfolding, and these unfolding molecules may refold to form the nucleus. And the nucleus can build up together to form the amyloid fiber structure. If a catheter tip is clogged with insulin amyloid aggregates, which are further enclosed by inflammatory cells, this may suggest that insulin aggregation is the leading cause of catheter obstructions. If catheter obstruction occur regardless of the presence of insulin, then catheter issues is likely to be a result of foreign body mediated immune response to the device, which is also known as foreign body reaction, FBR. FBR is a common issue for the implanted medical device. So following implantation, a series of inflammatory events can be initiated. So this is a mechanism of our body to protect us from the foreign body. However, like this mechanism can also impair the functionality of the implanted medical device. And here, this could also be a potential cause of catheter obstruction. As I mentioned before, tip obstructions account for the most cases of catheter obstructions, which includes tip blockage and tip encapsulation. In order to have a better understanding of the onset and progression of tip obstruction, I further divided the tip blockage into two subtypes. The first one, type 1 tip blockage. So this is means the tip end is partially blocked with a small blockage either near the distal open delivery port or near the inner small polyethylene tubing outlet, but with some empty space at the tip end. That is type 1, as the figure shown here. Type 2 is fully blocked with a large blockage occupying the entire space of the catheter tip end. Here, the blockage was removed from the tip end by a doctor for the image purpose. The last one, obviously, it is tip encapsulation. So histological evaluation was performed to determine the component of the blocked tissue. And we noticed that macrophage, fibroblast, as well as a collagen are the major components in the blocked samples. And here also shows an increase in the collagen deposition and decrease in macrophage infiltration with the development and the progression of catheter obstructions from type 1 to type 2 tip blockage to tip encapsulation. And foreign body giant cells were also observed in obstructing materials. All this evidence suggests that FBR plays an important role during this progress. In addition, elongated cells with fibroblast-like appearance were arranged in an ordered manner at the edge of most T block samples, as these gray arrows pointed here. So this triggered our interest to investigate the origin of fibroblast, and thus the phenotype determination of fibroblast-like cells were performed. Since mesenchymal cells are known as a main source of fibroblasts, and thus the intermediate filament protein vimentin is a marker of interest. According to H&E staining, epithelial cells were present in the blockage, indicating that epithelium-derived fibroblasts be also involved, and therefore PanCK was selected as an epithelial marker for staining. In addition, myofibroblasts are one of the phenotypes of fibroblasts which have the characteristics of smooth muscle cells, which helps wound contraction. Myofibroblasts are also known to be present surrounding peritoneal implants. Hence, the FSMA was utilized as a marker for myofibroblast. And the staining demonstrated that there is a reduction in epithelial origin fibroblast, but an increase in mesenchymal origin fibroblast from type 1 to type 2 to tip encapsulation. This implies that epithelial to mesenchymal transition is mediated in catheter obstructions. In addition, Congo red staining revealed that insulin aggregates were present in most of block catheters. So as this enlarged view of figures shown here, apple green color, like here, apple green color, represents amyloid aggregates. As you can see, these aggregates are present in the edge area of obstructing materials. So given that, we asked whether insulin stability could be an issue of catheter obstruction. Therefore, we collected used insulin samples from patients' insulin pumps and investigated the size and structure change in comparison with the fresh insulin samples. So here, this is fresh insulin sample, and insulin hexamer has a diameter around 5 nanometer, which you can see here. It is a mono-distributed peak. However, for the collected insulin sample, so this insulin sample has been remained in the patient insulin pump for 8 weeks. We did observe some large particles in the collected insulin sample, but these aggregates are reversible according to the SEC experiment. In addition, the secondary structure analysis showed a slight increase in the beta sheet content of collected insulin samples compared to the fresh insulin sample. It is still difficult to isolate the various possible factors in the clinical settings to identify which one is the leading cause. Even though, based on our investigation on clinical samples, insulin aggregates initiated immunogenic reaction or foreign body mediated immune response could be the possible cause of the catheter obstructions, but it's very hard for us to isolate or to study each individual factor separately. Thus, next step, an accelerated animal model is developed to reproduce all the failure modes of catheter obstructions. So using this novel animal model, a time-dependent study was performed in both an insulin-treated group and a placebo-treated group. Macroscopic and microscopic analysis was conducted with regards to the onset and the progression of catheter obstructions in order to determine, first, whether insulin stability is the primary cause of catheter obstructions, and second, to understand the dynamic cellular and molecular response to IP catheters. Visual examination demonstrated that the animal model had successfully reproduced the clinical failure modes of all three types of catheter obstructions, including tip blockage, tip encapsulation, as well as catheter encapsulation, as shown here. And then we use this animal model for further investigation. So here we have three groups. Top panel represents the group treated with placebo in healthy rats. Middle one represents insulin-treated group, also in a healthy rats. Bottom panel represents the insulin-treated group in a disease model, that is STZ-induced diabetic rats. Two highlights are on the slide. First, given the similarity in tip blockage and catheter encapsulation between the insulin and the diluent groups at each time point, insulin aggregates are unlikely to be the leading cause of catheter obstruction. Second, diabetic rats showed a slower progression of catheter obstructions compared to the healthy rats due to the impaired immune system of STZ-induced diabetic rats. Next, to further validate whether or not the development of catheter obstruction is related to the kinetics of FBR, we look at the dynamic cellular and collagen change with the progression of catheter obstructions. So for all groups, the fibrous encapsulation surrounding the catheter the thickness increase along with the duration of implantation. So as you can see here, from week 2 to week 4 to week 8 to week 12, the thickness of this encapsulation increased. In addition, from type 1 to type 2 to tip encapsulation, collagen deposition increased along with the reduction in macrophage infiltration, which is consistent with the classical pattern of FBR and are also in line with the analysis performed on the clinical samples. Furthermore, elongated cells with fibroblast-like appearance were arranged in an ordered manner at the edge of most tip blockage samples. We also investigated the phenotype of these cells using the same markers as we used for the human samples. So here, myofibroblasts-like cells are in red, mesenchymal cells are in pink, and epithelial cells are in green. And blue represents nucleus. In the early stage of catheter obstruction, like type 1 blockage, most of the pan-CK positive cells, the green cells, displayed a cobblestone-like morphology, but a few of them already showed a spindle shape, like the one here. Then for the samples with type 2 blockage, in places with high collagen accumulation, cobblestone-like cells positive for vimentin localized adjacent to the pan-CK positive cells, and some of these pan-CK positive cells also co-express the vimentin, alpha SMA, or both. And in the later phase, tip encapsulation as well as catheter encapsulation, a large population of fibroblast-like cells with spindle appearance occupied the edge of the blocked samples. The majority of these fibroblast-like cells expressed vimentin, alpha SMA, or both, and a small number of cells were also positive for pan-CK. The morphology and population change of different phenotypes of the fibrosis-related cells indicated that a certain amount of fibroblast-like cells originated from epithelial cells. So actually, the peritoneum is lined with a single layer of mesothelial cells, which shows certain epithelial characteristics. The loss of epithelial phenotype, but an increase in mesenchymal phenotype may be indicative of epithelial to mesenchymal transition. So this phenomenon was observed in the progression of catheter obstructions in both human and rodent subjects, implying that epithelial to mesenchymal transition mediated peritoneum irritation is likely to be involved in catheter obstructions. Overall speaking, mechanistic studies demonstrated that foreign body reaction to the device, IP catheter, rather than insulin aggregates formation, is the primary cause, which hinders the long-term maintenance of intraperitoneal insulin catheter. So this work provides insight to develop potential strategies to mitigate catheter obstructions, like for the perspective of FBR. So with that, I would like to acknowledge the funding agency, GDIF, for support of this project. I would like to also thank my advisor, Dr. Diane Burgess, as well as my lab members for their continuous help with my experiment. And I also would like to acknowledge my collaborators, Dr. Acknowledgement, who is a doctor as well as a professor from the University of Montpellier. So he has been working in the area of continuous intraperitoneal insulin infusion for decades, and he provided me a lot of knowledge for this area. And I also would like to thank Peter and Don from Physiological Devices. So they have like designed and manufactured the catheters for animal work. With that, thank you everyone for listening.